CME of the trauma webinar run by the West Zone Indian Orthopaedic Association. I take this opportunity to welcome every one of you all. And today the guest chapter with us is Kerala Orthopaedic Association. At the onset, may I call upon the Honorable President of West Zone Indian Orthopaedic Association, Professor Dr. Ajit Shinde, to give his welcome address. Over to you, Shinde, sir.
Good evening.
Good evening, sir.
Good evening.
Good
Respected
evening, sir.
guest, President-elect Dr. Atul Shrivastava, Vice President Dr. Ram Chadda, Secretary Dr. Naveen Thakkar, and my team members of West Zone IOA, Vice President Dr. Vikas Jain, Gujarat, and Dean Dr. Shivanand Bandekar, Goa, President and Secretary of Maharashtra and Gujarat Orthopaedic Association, Dr. Vasudev Gade Gune, Dr. Narayan Karne, Dr. Govind Purohit, and Dr. Kamlesh Marari, and all the respected faculty members. Good evening and welcome to fourth webinar of West Zone IOA. We have Kerala Orthopaedic Association with us today. I welcome President Ramakrishnan S. and Secretary Dr. Anthony Joseph, and I thank you for your support and participation in the today's CME. We have already talked about injuries around knee, hip, joint and open injuries. Today, we all dealing with the injuries around the shoulder joint. Being a ball and socket joint, it is a very much mobile, and injuries of the shoulder has become a common problem these days. Dislocation and fractures of the shoulder has variety of treatment available, including conservative management to replacement surgeries. But choosing right time for right patient is the utmost important. We have an excellent panel to discuss the issue today. With us, Dr. Prathap Kumar, Dr. Parag Shah, Dr. Vikas Agashe, and Dr. Dipit Sahu. I am sure this is going to be interesting discussion with our coordinators, Dr. Abhijit Kale and Dr. Ashish Phadnis, who are eminent surgeon and esteemed faculty with wide experience. Thank you, Abhijit and Dr. Ashish, for well organizing and coordinating the session. And thanks to Team Artho TV, Dr. Ashok Sam and Dr. Neeraj Bislani for collaboration. Thank you, everyone. Welcome, Shrivastava, sir. Now,
thank you, Dr. Shinde, sir, for his enlightening talk. Again, I take this opportunity to welcome the President-elect of the Indian Orthopaedic Association, Dr. Atul Shrivastava, sir. I and my co-coordinator, Dr. Ashish Phadnis, welcome all of you all to this fourth CME of the trauma webinar series run by West Zone Indian Orthopaedic Association. May I request the President-elect of the Indian Orthopaedic Association, Dr. Atul Shrivastava, sir, to say a few words. Over to you, sir.
Thank you, sir. Good evening, all. First and foremost, thank you for the kind invite. Friends, the West Zone has been a huge contributor to academics in the country of India. Since the inception of orthopedics in India in the year 1955, the members of the West Zone has contributed to Indian orthopedics in a huge way. I wish it continues in the same way. And you have mentored so many people, so many orthopedic surgeons all around the country, from north to south, from east to west, who are doing successfully well in their own fields. May it be spine, may it be arthroplasty, may it be trauma, may it be chest. I'm today in a chest conference, and it is today Dr. B.B. Joshi's birthday as well. So, and this vision of forming the West Zone, I congratulate Dr. Ajit Shinde, sir.
Thank you, sir.
Congratulations, sir, for the vision of forming this West Zone.
Thank you. Thank you.
Thakkar as the secretary, and Dr. Nara friend, and of course Dr. Kulkarni. It was their vision to form the West Zone and get it affiliated to the parent body, that is the Indian Orthopaedic Association. Sir, your contribution is unparalleled. Please continue that, and we sorry for some hiccups for joining late, but I'm always with you. Thank you so much. Jai Hind.
Thank you. Thank you, sir.
Thank you for those supportive and kind words from the which came from the desk of the President-elect of the
And not to miss Abhijit, Abhijit and Ashish, you are organizers par excellence. This is the way to organize things. This is the way to organize webinars. I appreciate that. Thank you.
Thank you. Sir, I take this opportunity to welcome you on the behalf of Bombay Orthopedic Society for the BIROC Max 2022, which will be held in Mumbai at the Geo World Convention Center from 29 to 31st of December 2022. As the President of the Indian Orthopaedic Association, it would be our privilege to host you at the conference. Thank you,
It
Dr.
would be my
Shinde.
privilege, Abhijit. I'll be there. Thank you.
Thank you.
Thank you so much.
Acceptance.
Thank you.
Today, the guest state association for this webinar is Kerala Orthopaedic Association, and we are privileged to have the President of Kerala Orthopaedic Association, Dr. Ramakrishnan sir, and the Secretary, Dr. Anthony Joseph with us. May I call upon the President of Kerala Orthopaedic Association, Dr. Ramakrishnan sir, to say a few words. Over to you, sir.
Hello, am I audible?
Yes, sir.
Yeah, good evening to each and every one of you. Respected Professor Shinde, Professor Atul Shrivastava, Dr. Abhijit, Dr. Ashish, all the distinguished faculty members. It is a nice occasion to interact with senior leading members of our profession on scientific aspects. And this topic selected today is a very pertinent topic, and the speakers are also equally good senior members who have excelled in their subspecialty. So thank you for coordinating with Kerala Orthopaedic Association. It is going, I think we should make it a regular feature to conduct webinars like this between the zones so that we interact better and learn from each other, and take this opportunity to thank each and every one of you for giving me this opportunity. Thank you.
Thank you very much, sir. Thank you very much. And with that, I would invite a few more people. I mean, we are joined by Dr. Parag Shah, who is the president of the Ahmedabad city body of the Orthopaedic Association. And Dr. Parag Shah is also an eminent upper limb surgeon who is also going to participate and speak on shoulder fractures subsequently. Our first speaker for today is Dr. K.R. Prathap Kumar, who is the president of the Shoulder and Elbow Society of India. He's a panelist of the Abhinav Bindra Foundation, and he's also the founder president of the SESI Kerala chapter. And he's an executive member of the IMA Kochi, and he's a trauma, shoulder, and elbow surgeon. It is our indeed privilege to have you here, sir. We have heard a lot about you, and we have seen your talks, but we are proud to have you as a part of our panel today. So over to you, sir, and you can start sharing the screen, sir.
Am I audible now?
Yes, sir, you're audible now.
Yes, I'm going to share my screen now.
Yes, sir.
Okay. Can you see my?
Yes, sir, we can see your screen, sir.
Okay, so I'm not going to waste any time. Non-union of the proximal humerus. That's what I'm going to talk about. proximal humerus fracture is on an increase. There are two reasons for that. One is a traumatic, high energy trauma. Second, that's for the youngsters. And second, most unfortunately, is the osteoporotic fracture, so which is becoming highly high incidence in India. What is happening here is people are living more and more. Our life expectancy in India is going up. Previously, it was 50. Now it is almost coming to 70. In Kerala, it is 74. So, which osteoporotic fracture plays an important role here. Now, there are certain controversies of the proximal humerus fracture as well. If you look at the literature, and if you look at traditionally, not to operate any fractures of the proximal humerus, just like your clavicle. Gone are the days. We have increasing knowledge of the biomechanics of the shoulder. Now, people have changed their thinking and their logic, and people identified there are certain fractures need to be operated, whether it is osteosynthesis or a replacement or a reconstruction. Okay, so you need to be a bit, you need to think about that and then do accordingly. Now, if you look at the non-unions of the proximal humerus fracture as such, so total is 1.1% in totally undisplaced fracture. You may think, oh, why there's an undisplaced fracture going into non-union? Yes, you may be looking at the X-ray, but there may be some other increasing energy dissipated at that time of injury. That may be the reason. Now, that dramatically increases to 8% if there is a metaphyseal combination. That metaphyseal combination is a very important word. We will discuss in next few slides. Okay, and again, it increases to more than 10% if it's a displaced or a translated fractures. What is this translated fractures? We will talk about. Displacement, you know, the usual description of more than 30 degree and more than 1 centimeter displacement. Okay, and angulation more than 30 degree. This is a paper. If you look at that, is one of those major trauma centers in the world. I've been there in Edinburgh, and from Professor Margaret McQueen. They got a database of a trauma from 1980. Probably they will have the oldest database, and this is the data from them, from Edinburgh. Now, if you look at the risk factors, we just talked about some risk factors. The others are a head shaft angle. Most of you are very familiar with your hip, the Shenden's line, and your neck shaft angle there. Similarly, the neck shaft angle is roughly between 130 and 145 degree. And if the neck shaft angle is going to be below 90 degree, that's going to be a significant risk of non-union there. Okay, that means a varus. Okay, why this varus? We'll come to that in a minute. And again, the head shaft translation, a translation more than 1 centimeter, that will give you increasing problem with your vascularity and soft tissue rupture. Okay, so that is why the head translation also make an important role. And this paper, particular paper, where they looked at 3 different aspects: head shaft angle, head shaft translation, and smoking. Okay, and they have found a very big correlation between them. Now, it is very important to know what is this medial calcar, because that is one which is giving you a metaphyseal support and metaphyseal combination, which I was talking about previously. It's just like your hip joint. Okay, you got a medial calcar in the hip. Similarly, you got a medial calcar in your shoulder as well. That is exactly between your surgical neck of humerus and your anatomical neck. That part. Okay, you can see that that line, that angle there, and that will translate to about 1 centimeter, less than 1 centimeter there. Okay, and that is very important. Why that is important? That is because that is where all these vascularity problems comes in. Okay, the head of humerus vascularity is mainly dependent on the anterior and posterior circumflex artery, which make an arterial arcade and goes into arcuate the arterioles and branches. So if you have a 1 centimeter spared there, you are fairly okay, and you can predict or assume that your vascularity is going to be fine. If you look at this schematic representation here, here is a displaced fracture, very much displaced, not that much displaced. But if you look at here the medial calcar is very less, whereas you got a entire medial calcar here attached to the proximal. So I will go with that. I will favor this one. This will heal better with a better vascularity. So where this is a higher chance of preserving the arterial arcade. Why you want to fix it is all about getting a normal anatomy into your shoulder. As Shinde sir said, it's one of the joints with the maximum mobility here, and you need that shoulder joint to reach anywhere. And especially in the old age, you have more and more Indian people are becoming independent, staying alone, so they need an independent shoulder, okay, independent arm movements. So this is all about reproducing the bony structure as well as the biomechanics. Unless you get a normal biomechanics, you won't be able to get your movements back because of your particular arrangement of your rotator cuff. If you look at that, it's all about getting the function of your proximal humerus alias function of your shoulder, your glenohumeral joint. That is by getting the center of rotation correct and by getting the force couple in a balance. Okay, so that is why we want to keep the greater tuberosity and lesser tuberosity intact where it should be anatomically attached. And that is the way of getting the biomechanics back. Unless you get a balance of these two, anterior cuff and posterior cuff, your force couple will be deranged and you will end up with a lot of problem, including your range of movement and your arthritis, rotator cuff arthropathy. So I'm not going into the details of that now. Okay, so our consideration is to get the biomechanics back, a biomechanical fixation back, and an articular surface preservation. These are the important things. So there you need to consider the surgeon's factor and the patient factor. Surgeon's factor, definitely knowledge of anatomy and biomechanics is very important. And that is why all these CMEs are all about. We need to get more youngsters more and more trained into this sort of situation. And we need to have, the surgeon should have a various fixation types, knowledge about various fixation types, and expanding range of reconstructive options. Every day, newer things are coming to the market, and we are successfully utilizing that. So they should be aware of that. And these sort of CMEs are very important for that. And of course, the experience of the surgeon. Now, the patient factors, especially the personality of the fracture pattern, okay, comminuted fractures and small fragments, medial combination, all these things. Then quality of bone, as I was talking initially, is the osteoporotic fractures we are worried about. Okay, increasing incidence of osteoporosis nowadays in India. Then the quality of the soft tissue is equally important. I think it's more than anywhere else in the body. The soft tissue plays a very important part around the shoulder, because that is the one which is going to dictate terms of the function of your shoulder joint, and of course the comorbidities. Now, what is the role of CT? The fracture pattern is an important consideration, okay, in deciding upon the treatment of and predicting the risk of AVN and osteonecrosis. So we need a CT. As I said before, if you look at a plain X-ray, okay, in the anatomical, you need a 20-degree external rotation to look at the medial calcar, because it's not medial, it's posteromedial slightly. So in a trauma situation, it's very difficult to get a external rotation, patient in an external rotation of their arm, because it's painful. So you need a CT, and you need to look at very carefully at the CT. So these are some of those papers for AVN. And here, there's an important question to answer: AVN versus biomechanics. I will go with the biomechanics. I don't mind, even if there's some AVN, if I can get an integrated soft tissue around the shoulder, then I got a second chance to do something else for the patient, which is even a replacement. Okay, because once the biomechanics is completely gone, then we can't do anything for that patient. We will be helpless as a patient, as helpless as the patient. Now, so it's very important that there are two types of non-unions we need to talk about. One is your innate non-union. That's a primary non-union. You decided to treat them non-operatively and end up with the non-union for various reasons. Maybe due to stability, maybe due to your biology, anything. And second thing is second category is you have operated on that patient and failed operation with the failed union. So it's your problem now. Okay, patient's problem is shifted to the surgeon's problem now. Okay, so you got a chance. You need to correct it on day one during the first surgery. Okay, so these are some of those steps I do during the initial surgery. I'll put a Steven pin and I can put the periosteal elevator to make sure that the medial calcar is back to normal. And once the medial calcar is back to normal, I'll put some K-wires, thick K-wires to hold it, and then I will do that fixation, and then do the neutralization of your cuff. The neutralization of the cuff, I will talk in a minute. Now, this is certainly a failed surgeon. Okay, you can see that this is probably one of the previous plates, and you can see that it's not adequate enough. That is the result. Okay, I won't be surprised. So now you'll have to sort it out. Now I'll go to the see again a failed surgeon. He got the main fragment healed, very nice, no problem. But the patient is not going to lift up his arm because the function is lost here. You can see that a greater tuberosity is there, which is going to control the movement of here. So you can take it out, the whole the plate and screw out, and you can neutralize the cuff. Now this I will show you 3 patients, and this is a 67-year-old female patient who was a homemaker. She fell in the bathroom, 4-part fracture. She was treated non-operatively by the surgeon who has seen her because of a lot of comorbidities, poorly controlled diabetes, hypertension, all these things. So after 8 months, tenderness all around the shoulder, stiff shoulder, pain inhibition, she couldn't move the shoulder at all, and she wants to be independent. She don't have any shoulder movements at all. This was the X-ray. We don't know what is what. So we went for the 3D CT, defined it, and then went for a Delta approach and fixation. Okay, so my fixation is we open the medullary canal, clear it off, remove all these monkey tissues, including fibrous tissue, and then this is my most favorite technique. I'll take a corticocancellous graft, roughly 5 to 6 centimeter size, put it intramedullary, and then support it as a medial calcar. Okay, I don't know whether you can see that on this side. So it's roughly 5 to 6 centimeter. That's a very good one, and you can see that that convexity will go medially, so that it will go and impact onto the medial side of the humeral head. So that will be a very good fixation. And usually what happens is that you will have at least 2 screws going through that graft as well. And then, of course, we will neutralize the cuff and do the fixation. Okay, and you can see that this is my graft. Okay, and this graft is left like this. Okay, like this, so that it will hold on to. And there are at least 2 screws going through that. It's very stable, and that is the result after 8 months. You can see that. Okay, so she had a painless range of movement, fairly not full, but she had up to 130 degree, and she was quite happy with that, and she was independent. And the more than that, she got the rotation also right. So she was quite happy with that, and Yeah, you can see the rotation, external rotation, and also probably the internal rotation she may show. Yeah, internal.
So I think we have lost your voice there. Can you just say that again? The last few slides. No, Abhijit, can you hear what Professor is saying?
No, Ashish, I can't hear it. Probably what we are seeing.
Yes, sir. Now we can hear you again. Yes, sir. We can hear you, sir, again.
No, Ashish, probably we are.
I think his internet is a little bit unstable. We can try it again. Yes, sir.
No, we can't hear him, Ashish.
Can I use my mobile to talk?
Yes, sir. Yes, sir. We can hear you now.
Okay. Okay.
So what
Okay,
you can
fine.
also do is you can just stop your video and just continue screen sharing and the audio.
Yeah, that's.
Okay.
I mean, it's okay. Whatever you're doing is working now.
Fine.
Yeah.
Okay. This is the patient, and the patient. Now these patients usually what happens is they will come as a pseudo paralysis. I don't think that is. That's not working. Okay, leave it. Okay, the last patient is 47-year-old. Clergy with a BMI of 48. He had a displacement fracture, had a prolonged surgery somewhere outside the town, and he was taken back to the OT on the third day. And you can see that patient came to me after 4 months. You can see that the greater tuberosity is closed, and also some screws are independent. Okay, so patient came with the pain, stiffness, and no movement. We had a CT scan, infection screen, and a counseling. We had to revise it, went in, opened it, and removed all these plate and screws. And then the main fracture was united, and the greater tuberosity we did. You can see what I have done using some screws, attention band wiring, and he was happy. 9 months down the line. Okay. Now there is some talk about double plating, which I don't favor. I always use corticocancellous graft. So take-home message is all about recreating your soft tissues, recreating your biology, providing stability, and taking care of a bony congruence. Thank you very much. I'm really sorry about the poor audio quality. Welcome for this.
No problem, sir. So this year it is on 28, 29, and 30 at Kochi. Excellent, sir.
Sorry about it.
No, not a problem, sir. I think the voice is echoing because there are two devices which are logged in. Let's check if you have any questions coming in. So let me start asking you a question. Is that most of the non-unions that you said now that you have shown is basically a surgeon-related problem, that the fixation failed, the mechanics failed, and then
not most of them. Not most of them. Don't take me wrong. I had a few of them, but
right.
The rest of them are primary non-unions.
Right. So, I mean, there was this paper, very talked about paper called the PROFER trial, the PROFER 1 and the PROFER 2. And me and Dr. Dipit also have sort of debated in our journal clubs also about the strengths and the weaknesses of the paper. But that paper seemed to have planted a lot of doubt in the general orthopedic surgeons' minds regarding the choice of fixation, isn't it? I mean,
exactly. See, there are very specific indications for fixation. See, you don't need to fix each and every proximal humerus fracture. And if you think you cannot fix it properly, leave it for non-operative management. That will be better.
Right.
And not take me wrong. If you don't have that resource at that time, don't attempt a fixation with the whatever is available. You need the proper resources.
Right. Okay. So any of these occasions when you have found that when you go in for a surgery, that if the implant is there, and like what happens in the lower extremity, that the implant is there and underneath you will find that the bone is quite atrophic or the tissues are very atrophic. So does that become much of a problem? Because we used to hear things like using an intramedullary fibula not so long ago, about I think a decade ago, people used to use and stuff a big intramedullary fibula, get it in nice valgus, and then suture everything on. So do you have to do that often?
No, I never use the intramedullary fibula because what I need is a 6 centimeter vertical cancel graft, which I can get it from the iliac crest.
Okay. Okay. And then you have mentioned that there was this failure of mechanics and biology. So in these particular patients, would you consider a replacement at some point, or would you err towards fixing as a natural instinct?
Yes, my natural instinct is to fix it always, because if you look at the for a trauma, it will be very bad, and a younger patient really want to put it.
Okay, so Dr. Parag is also here, and Dr. Parag, and he's going to follow his talk, which is going to talk about replacements. But this is a different point of view. As a trauma surgeon, you would generally err towards fixing it and trying to restore the biomechanics. But a replacement also would be there. So, Dr. Parag, in your hands, I mean, have you seen such situations that you have debated yourself between fixation, bone grafting, restoring the biomechanics, or you have a low threshold towards replacing?
So, Ashish, can you hear me?
Yes, we can hear you.
Perfect. So I think there is always this dilemma, in terms of what you want to do. But at the end of the day, we tend to look at the age of the patient. We get to look at the MRIs and see what the fibrosity looking like, how good is the cuff. And at some point in time, especially when we're talking about India and our patients, affordability is always to be kept in mind as well. So I think just as Prathap showed, there are a significant number of cases where you can salvage it either by intramedullary fibula or by a corticocancellous iliac crest graft, double plating, and what have you. So I think in my hands, patients under 60, 65 are the ones where I strive to sort of get back, the anatomy by fixation, and whatever means of bone grafting or, something to add to the biology is something that I would do. Beyond 65, beyond, 8, 9 months or 10 months of a persistent non-union situation, I think I would tend to err more towards giving an arthroplasty to those patients. So I think age and the condition of the rotator cuff are the two things that decide my treatment for non-unions.
Right. And sir, you mentioned initially about smoking being a big risk factor, and everyone keeps on talking about smoking. Now, how big is that a problem in a patient who's a relatively non-compliant? I mean, do you actually look for it that whether this gentleman has stopped smoking, or would you pass the onus on to him that okay, you are still continuing to smoke and you are at a higher risk?
You're asking me?
Yes, sir. Yes, sir. I mean,
okay. I think that was one of those papers from Margaret McQueen. And they have clearly looked at smoking as a villain, and they clearly do it. But it's very difficult to take. It's a trauma situation, and you have to go ahead. You can decide. And there is no point to just stopping the smoking very recently, because the effect is up to 10 years if you look at the literature.
Yes.
The nicotine effect is up to 10 years. Yes.
Right.
So I don't mind. Well, there are uncompliant patients.
Right. Okay. Any questions, Professor Shinde sir, Abhijit?
No, Ashish, no
Okay.
questions. You may continue. Very well explanatory talk.
Thank you.
Excellent. Thank you very much, sir. We'll
Thank
be
you.
taking the questions on the Ortho TV channel and the YouTube channel as they come. In the meanwhile, I'll invite our dear friend and colleague, Dr. Parag Shah, who is a very regular feature on our webinars from the West Zone, Bombay Orthopedic Society in Maharashtra. And so he's going to talk to us today about the replacement options and reverse shoulder replacement for proximal humeral fractures. Over to you, Dr. Parag, and a very warm welcome from the West Zone to you. As the president of the Ahmedabad Orthopaedic Association, we do warmly welcome you again.
Thank you so much for this invite, and thank you everyone for this talk. I'm going to try and share my screen now.
Rishi, can you just see if he needs any help?
Hello, sir.
Yes.
Hello.
Yes.
Rishi is
Hello?
from Ortho TV, Parag.
Yes. Yes. Somehow I'm not.
Click on that green arrow, screen share.
Yes.
Sharing the screen.
Yeah, that's what I'm doing.
Yeah, that's what.
Just give me a second here.
Yeah. Dipit, are you there?
Yeah, I'm here. Should I take it?
Dr. Parag, just let Dr. Dipit take the talk first.
Till then he'll figure it out.
I think so. Dr. Parag, can we take Dr. Dipit's talk in the meanwhile? I think.
Sorry.
Yeah, Dr. Parag, can we take Dr. Dipit's talk in the meanwhile?
Yes. 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 Why don't we do that?
Okay. Yeah. Excellent, Dipit.
1 second. Okay.
So Dr. Dipit Sahu is a shoulder surgeon, and he is attached to Jupiter and HN Reliance Hospital, and he's a prominent member of our society, Bombay Orthopedic Society. He is one of the editors of the Journal of the Shoulder and Elbow Surgery. He's got a lot of publications in the shoulder world, and he's often very active in academic circles, and especially during publications, and was very active during the COVID times, and has got a couple of articles to his credit with regards to the shoulder injury related to COVID vaccines. Dipit is going to talk to us on neglected pathologies and shoulder dislocations, both anterior and posterior. Yeah, over to you, Dipit.
Yes, I've just switched off my video because the network
that's
was
fine.
weak. So I'll just speak, and maybe you'll see my photograph later on. And thank you, Dr. Phadnis. Abhijit ji, thank you very much. Dr. Shinde, thank you for having me here. I would like to express my gratitude to Maharashtra Orthopaedic Association, the Kerala chapter, for listening to me. In this talk, I'll be speaking on the neglected shoulder dislocation. This whole talk is based on my experience because there is not much evidence in towards any particular form of treatment, but this is based on what I've studied, I've read, I've done, and the experience continues to grow. Things may change tomorrow when I give the same talk after an year, but this is what it stands today. The first topic, the first thing that we should decide when to call a shoulder dislocation as neglected, or after how many weeks of no treatment. It could be 1 week, 3 weeks, 6 weeks. It could be a personal thing also. Some people may say 2 weeks, but broadly, either it will be one of the three, 1 week, 3 week, or 6 weeks. And everybody may have a different sort of opinion to it. But what about Dr. Phadnis? What do you think would, in your opinion, would be, when would you call a dislocation as neglected? And Abhijit ji, can you also opine? And Dr. Prathap.
I think, I mean, as general trauma surgeon, probably anything that is dislocated needs to go in fast. So I probably will err about a week.
Okay. Abhijit ji, what do you say?
Yeah, I guess if you follow the literature, the classical teaching has been 3 months.
Yeah.
I think untreated, undiagnosed, probably.
Yeah. What about you, Dr. Prathap? What do you say?
Yeah, I will go with the 3 months, but 3 months probably is a bit on the twitchy side. 6 weeks.
Yeah, so see, you know, there are so many articles I went through. When is it called neglected? What time point? Because we need to be speaking the same language. I call neglected somebody sitting in Malaysia or somebody sitting in Africa, or for that matter, United States, to call it neglected should be speaking the same language. And generally speaking, it should be a time point after which closed reduction should become very difficult to achieve, if not impossible. I wouldn't say impossible, because there are reports, some people have said that they've achieved a closed reduction with some difficulty even after many, many weeks. But there has to be some sort of agreement to it. And I went through the literature, read many, many papers. And this is my paper. We wrote it Jupiter. And this is one of the landmark articles by Rowe and Zareen, was written in 1982. And so even they agreed, and I found mostly if you call it 3 weeks, it should be agreeable to most people. Not everybody. Some papers I've read, they said 6 weeks. Some people have said 3 months. Some people have even said 2 weeks, because they think even after 2 weeks, it is very difficult to achieve a closed reduction. So, but I mean, we have to agree on something. So as per my paper, this is what we are quoting now. After 3 weeks, your chances of closed reduction are very bleak. It may still be possible in an odd patient. You know, it may still be possible in the old patient, you know, with a very lax muscle. Possibly some people may achieve closed reduction after 5 weeks. But I generally would say at 3 weeks, there are chances that your closed reduction will fail. There are high chances, not always. We never say always, but 3 weeks is what I would say now. And this is what I've published. We published, and this was a paper from Jupiter. More importantly, we saw, and my practice, the resurgence of neglected shoulder dislocation was seen in COVID times. At one time of point, I was seeing 2 or 3 in one OPD, which never ever happened. We used to see 2 or 3 in 1 year. And even then they probably went away, but there were high numbers seen during COVID, not only of shoulder, it was also probably of elbow and other regions. But yes, definitely shoulder dislocation, people were a little bit hesitant in seeking out treatment. Now, I would take you through the treatment of both anterior and posterior neglected, but anterior I have divided into 2 based on my personal experience and how we classify it. So if you catch a patient who is more than 3 weeks, which is called neglected, but less than 2 months, and somebody who's more than 2 months, this is just based on personal experience, and it may change tomorrow, but I have a substantial experience now in this category of problem. So if you catch somebody, and I've had some patients who in less than 2 months, the close reduction wasn't possible. They were old ladies, 65, 70 sometimes. And I went in to do an open reduction, and I was able to preserve the entire subscapularis. So entire reduction, open reduction was done through the rotator interval. And once it was done through a split of the subscap, but no subscap was ever removed. It was kept intact. So this is a major factor because your prognosis improves significantly, your rehab decreases a lot, excuse me, and your results improve a lot. So this was possible in some ladies who presented in about 2 months or less than 2 months. And in this case, I'll show you this patient who presented at around 3 weeks. She had a cuff tear as well with a 3-week dislocation anterior. And we went in with an arthroscope. And this is I'm viewing through the lateral portal. And we saw the head is dislocated anteriorly. Now, if you see on the right side is the humeral head, left side is the glenoid. So it is actually, if you see it is dislocated anteriorly, the subscap was intact, but the supra-infraspinatus was gone. And in this case, which this technique we published in arthroscopy techniques, this reduction was achievable by arthroscopic technique. So we made another portal, we pushed in a periosteum elevator. Why I'm showing you this is because even the open reduction will be done through the same principle. So I just pushed in a periosteal elevator in the cavity in front of the humeral heads, and then levered the humeral head back in front of the glenoid. This was possible because this was early. This was around 3 weeks or something, between 3 and 4 weeks, not very late. It may not have been possible if it had come after 2 months or something. But we did it because we had to do a cuff repair as well. So this was achieved entirely through arthroscope, the reduction as well as the cuff repair. And if you see, at 6 months, she had full function and no pain. When initially she was very, very painful. And this is the X-ray which showed that the head was firmly in the joint. Now, if you have a patient presenting late, it could be 3 months, 4 months, 6 months. There have been patients to me at long as 4 years after dislocation. 2 things you need to decide. So first is your coracoid osteotomy, which may be frequently needed. Now, if you see on the left X-ray, you draw a line below the coracoid, and if you see the shadow of the LT is just below it, then you may get away without doing a coracoid osteotomy. However, in the right side of the X-ray, if you see, the shadow of the LT is quite medial to the line extended from the coracoid. You will need a coracoid osteotomy to expose the LT and the subscap in this case, and it will allow you to access the humeral head after the osteotomy. Now, this has been our experience, and this is what we published also, that the coracoid osteotomy is fixed back. I used to fix it with a screw, now I fix it with anchor. There is a contention that should latarge be performed. It is a very highly debatable issue, but mostly there is a very big study published in JBJ said it does not improve your success rates if you transfer the coracoid to the glenoid, or in other words, if you do a latarge, it doesn't change anything. If it had to dislocate, it will still dislocate, because this is not the same condition as a recurrent shoulder dislocation, for which latarge was discovered for what is the primary indication. So latarge primary indication is a recurrent dislocation. A lock dislocation is a very argumentative, very contentious issue. It may not be the most recommended thing to do. And we have recommended in our paper to best avoid at this moment, because first, we don't have much evidence, and the evidence that we have goes against it. So, for example, this young guy during COVID times was out around 3 to 4 months of dislocation, did not do a coracoid osteotomy, just removed the upper part of subscap and repaired it back, of course, reduced it, repaired it, and he had full function. His shoulder subjective value was 90%, and he had extremely good results. Now, frequently we found that the humeral head will be very unstable in front of the glenoid. With slight movements or rotations, the head will slip out. So this is what we recommend: pushing a K wire or 2 K wires from the acromion to the GT or the humeral head and fixing it in place for 4 weeks. You can remove it after 4 weeks, but it will be kept in place with these K wires, and you give an mobilization. What we've seen that if there is irreparable, for example, in this lady, who was a rheumatoid patient, and if there is a cartilage damage, you should possibly go ahead with a reverse shoulder rather than anatomic, because there are better chances of it being stable, and anatomic may be unstable. And this is what we found in our review, which we published in JSC's Review Reports and Techniques, that the anatomic replacement is not as stable as the reverse in cases of neglected dislocation, where you do have to replace. Now, if you consider the posterior neglected is a slightly different issue, because it is definitely better where prognosis is concerned. The results are more predictable and more defined. Pain-free patient, good range of motion, they are all achievable by an open reduction and a McLaughlin procedure. What we do in McLaughlin is we do a medialization of the lesser tuberosity in the defect which is created due to the dislocation, or the reverse hill sag, you can call it. But if you reduce it, you do a medialization of lesser tuberosity, which is called the McLaughlin. You immobilize for 4 weeks. You start your movement after 4 weeks. The results are very predictable, as I would call it, and not as variable as in the anterior dislocation. So this is what our experience has been. We've had 26 cases. We have followed 1 to 5 years. We've had 2 resubluxations, very complicated cases. We had a coracoid migration, after which I changed from screw to a anchor fixation of the coracoid back. And we've published a couple of papers, and this is our experience that I would just summarize. And our 5th paper will be coming up by the end of the year. But anterior neglected outcome may be variable, but pain relief is usually good. Now, you can use the following techniques. You can use a coracoid osteotomy, a subscap removal and repair. Definitely repair. You cannot just leave it like that. And then a K-wire to fix acromion to humerus. A posterior neglected has good prognosis with McLaughlin. And a reverse shoulder should be preferred, if you can, over an anatomic when there is a cartilage loss or irreparable cuff loss. Thank you.
Thank you, Dr. Dipit. Dr. Prathap Kumar sir and Dr. Parag, I mean, do you have any questions or comments?
Yeah, I think I haven't seen much of neglected anterior dislocations here in Kerala recently, but still we come across the posterior dislocations. I don't get that many numbers. I will get 1 a year maximum.
Correct.
And my preferred technique is a McLaughlin's.
Yeah.
For that. Yeah.
So again, I agree. I concur with Prathap and Dipit that I think the neglected posterior one is much more common than the anterior one, because sometimes the imaging is very innocuous. The X-rays look pretty normal, especially when only an AP view is taken and not a whole trauma series. But then you need a very high degree of suspicion clinically. Any patient coming with loss of external rotation, with a history of either trauma, epilepsy, or electric shock, and then it must sort of occur to you that we may be dealing with a posterior dislocation. So yes, we also have an extremely large series of locked posterior dislocations with a follow-up between 1 and 6 years now. And a modified McLaughlin is probably the treatment of choice for posterior ones. And most of them do extremely well, but now we are coming to a situation where our own cases are now beyond 5 years, and we do see between 10 and 20% of them having early changes of avascular necrosis, although it doesn't change entirely their clinical profile or their result. But I think it is something to keep in mind that over time, many of these can develop avascular necrosis. I think for me, a cutoff time is 6 months. Beyond that, I think I do attempt a reduction, open reduction, of course. Most of the time, we will succeed in getting these posterior dislocated heads back, but the rate of avascular necrosis increases significantly within 1 year when the initial dislocation has been neglected for more than 6 months. And again, entirely agree with Dipit that the anterior ones are less in number. They're significantly less predictable in terms of how they're going to do because of two things. One is the subscap, and the second is anterior glenoid bone loss. We haven't found a significant posterior glenoid bone loss in locked posterior dislocations, but in neglected anterior dislocations, you do find significant glenoid problems. So, we have issues with subscapularis, we have issues with the glenoid as well. So they make it more difficult to treat. I think that's my take on this.
Well, thank you very much. Any closing comments, Dipit? I think Abhijit and Shinde sir, any comments on whatever has been said so far, or in your experience? I mean,
Shinde sir first.
I agree with Parag Shah.
excellent. Thank you very much, Dipit.
Thank you.
Thank you. Just hang around for a while, and we'll be back to you. Dipit also has got a good case to show, and we'll move on to Ahmedabad. And Dr. Parag, welcome.
Thank you. Am I successful in?
Yes, absolutely.
Share?
Yes,
Awesome.
we can do that.
Very good. So I'm just going to start the slideshow as well. Okay, so my talk is on reverse shoulders or reverse shoulder arthroplasty for fractures and its sequelae, and I just titled it like "Is reverse the way forward?" because of things that I'm probably just going to talk about. So we'll just again start with this particular case. This is a 69-year-old lady. If she were just 1 year older, she would have got the 70-year threshold, so making decisions a little bit easier because you reach 70, the magic figure. But so this is 69, a domestic fall, diabetic, hypertensive, blood thinners, obesity, already has bilateral TKRs done, but it's still a community ambulatory. She's active, and she sort of is an entrepreneur of sorts, doing her business. So we have this group of, as Prathap already said in the beginning, elderly, active, independent population with poor bone quality and fractures that perhaps require operative management, depending on whatever your take on the profit trial is. So this is kind of an X-ray, doesn't show great quality of bone. There is already a subacromial spur here, so that gives you an idea about probably some ongoing rotator cuff issues. That's a CT. We'll skip that. That's the 3D. And that does show an element of a head split here and a tuberosity which is displaced. So I think this does fall into a category of a fracture which might not be the most amenable for fixation. So now we are talking about older individuals with complex fractures or fracture dislocations, where you perhaps might still think about non-op management if the patient so desires, or because of comorbidities, you can't really operate, but then you're left with fixation, which sometimes is suboptimal. And then you have a hemi arthroplasty and a reverse shoulder arthroplasty for these patients. This is another individual, a 75-year-old lady, had been treated for, surprise, surprise, a frozen shoulder, and manipulated, put up with full range of motion on the table, but the post-procedure X-ray suggested that there is a fracture of the surgical neck. But what you see here is, a missed arthritic shoulder, which was mistakenly treated as a frozen shoulder. So now she's 75, has a fracture of the surgical neck with large osteophytes, as you see here. So the question is, what would you do for this? Would you go for a fixation? If you wanted to do a hemi or a total, you wanted to have good salvage of the tuberosities and a well-functioning cuff to maintain your biomechanics. So again, a query as to how would you deal this patient as well. And again, not so infrequently, we get a relatively younger patient with a sequelae of a 4-part fracture dislocation, whereas you see the head is malpositioned, it's anteriorly subluxed, and you have fair bit of pieces here, and I'm sure some of them were the tuberosities which have not been fixed in the primary fixation. So these are the ones which are painful, which are pseudoparalytic, and are begging for something to be done. So the problem is mostly a displaced proximal humerus fracture in the elderly with compounding issues of poor bone comminution, a poor cuff. Fixation is arguably difficult, and we do have problems with Hemi Arthroplasty, and we all know that a primary surgery done is better in terms of results than something that is done as a revision surgery. We also unfortunately see more than the fair bit of these cases where hemis are being done for proximal humeral fractures. There is absolutely, this is non-modular. There is no way that tuberosities are going to stick to metal, and predictably the tuberosities fail, the prosthesis fails, and then this again is a painful, unstable pseudoparalytic shoulder with a Hemi Arthroplasty. Again, if the tuberosities fail, then your prosthesis is going to proximally migrate. As you see here, it's just under the surface of the acromion, and the literature is quite significant in terms of poor results of Hemi Arthroplasty. And again, sometimes you have complete tuberosity resorption, and that's the left upper extremity, which is pseudoparalytic with no function whatsoever. So we have issues with Hemi Arthroplasties either done primarily or for failed fixation, and then they in turn continue to have poor results. So why reverse? We do know from our own experience and global experience that it is the treatment of choice in shoulders which have poor rotator cuff, irreparable rotator cuff tears, or frank cuff tear arthropathies where you have arthritis and no cuff. And we have extrapolated the results and tried to do this in trauma cases over the last 15 years with significant success. So the reverse basically changes the biomechanics of a shoulder. Now, if you consider this particular shoulder, whether it's a fracture hemi or a primary cuff tear arthropathy where the proximal humerus is migrated up, the deltoid is unable to function here. Okay, and when you do a reverse, you basically are distalizing the humerus, you are medializing the center of rotation, and the deltoid then takes over the function and can function sufficiently even in the absence of a functioning rotator cuff. And therefore, the potential benefits of a reverse shoulder are less reliance on pure tuberosity union. We do seem to believe that the tuberosities appear to heal better with a reverse as compared to a hemi. And we do end up with a more predictable forward elevation and abduction, and hence better overall function and satisfaction when we do a primary or a revision reverse shoulder arthroplasty. So in my practice, the indications are acute 4-part fractures, fracture dislocations, head splits, obviously poor bone in advanced age with significant medical comorbidities, or somebody who already has a pre-existing degenerative joint disease or atrophy of the cuff, and obviously for sequelae of treated or untreated trauma, where I think there is nothing else but a reverse which might give some hope of a function. Again, the approaches are the two which are commonly used, the deltopectoral or the deltoid split. My preference is usually to go for a deltopectoral approach. And again, although I've been talking about the fact that the reverse can work in the absence of tuberosities, when you're talking or the absence of rotator cuff, when you're talking about the reverse shoulders in acute or in sequelae, we still try to salvage the tuberosities, because the rotational ability, especially the rotation in abduction, is something which is extremely important functionally, and you will only get it if you have a good tuberosity and a good rotator cuff. So again, as you see, that's the fracture. The head has been excised, but then I want to salvage the GT and the LT to eventually fix with each other and the shaft and the prosthesis. This is a typical case where I would use a reverse, where there is obviously pre-existing degenerative disease. The head is completely arthritic, and actually so is the glenoid. As you see, there's a large rim
of osteophytes on the glenoid side as well. And that's sort of the exposure of the glenoid that you can get. And the reverse basically reverses the polarity of the shoulder. So you have a glenosphere on the glenoid side, and that's the one in position. And again, then you trial this, and again, make sure that your tuberosities, your GT and the LT, are coming as close to anatomy as possible to get the best stability as well as post-op function. And again, as has been emphasized, even when you're doing a hemi or a reverse, the idea is to get a very nice closure of the rotator cuff and the tuberosities to give the best function. So one of the common prostheses that we use is the one which is designed specifically for trauma, which is, we call that a platform stem. So you can do a hemi on this, or you can do a reverse, or you can shift from one to the other. In the primary or a revision situation, it is proximally coated to enhance tuberosity healing. It is specific holes to pass your sutures to tie your cuff. And as you see here, a dedicated platform stem, you could probably do a hemi and even a reverse on the same stem. So again, this was the patient that we discussed before, and we also went ahead and did a reverse in this situation. This is now almost 9 or 10 years. She's in her mid 80s, and she's still doing very well. The last time we saw her was quite many years ago before COVID, and she has excellent function. As Prathap said, if you have non-unions, you could go and try and fix them. But again, in patients over 75, when you have a situation like this with poor bone quality, I think for me, the go-to approach is with a reverse. And there is a fair bit of predictability when you do a reverse in these situations also. And again, this lady who was in her late 70s when we did the procedure is now well in her 80s and continues to have excellent range of motion. This is a salvage situation where, we were forced to do a reverse in a relatively young patient because, it's 1 year and I don't think there is anything that I can do to get him better biomechanically. The head, that's the head. The head still had capsular attachment to it. It was still vascular, but the tuberosities were completely off. And this is what we could do. And this was at about 4 or 5 years, and that was his function at that time. This was the scar of the reverse, and this was his original approach. And then he had a very satisfactory result after a reverse shoulder arthroplasty. And sometimes we have malunions, which are very problematic. Again, in a relatively young individual, somebody stuck in a hemi, and that failed in a couple of years. And again, the bailout was reverse shoulder arthroplasty for this failed hemi arthroplasty as well. And that's her result at about 5 years of the reverse. And she's now in her mid 60s and is maintaining an excellent function with a reverse shoulder arthroplasty. The final case here is, these are bad fractures and they should be done in a primarily as a replacement case rather than trying to attempt a fixation where you're not able to get a good reduction, in the primary surgery. And then we had to intervene, and we did a single stage reverse. Thankfully, there was no infection. And even at the age of 79 or 80, at about a year's time, this gentleman has had a very good painless shoulder with a good range of motion. So going back to the first case, this was the kind of tuberosities in that lady, and you can't expect these to unite well in a hemi arthroplasty situation. And I think the reverse is the best situation for her. This is a greater tuberosity. A lot of it is bare. She has no supraspinatus. The infra is also not the best looking one. There is just a part of the head attached here. So I think it was a good decision to do a primary reverse shoulder arthroplasty for her. And again, trying to get the tuberosities back to each other and trying to get them to heal in a near anatomic position would give the best possible result for this situation. And that was her post-op case. We did a LinkedIn poll for this with a lot of people commenting on that. And I think globally, it was quite acceptable to do a primary reverse shoulder in a 69-year-old lady with this anatomy. There is enough evidence in the literature about hemi versus reverse shoulders. There are prospective randomized level 1 trials as well. And most of them are suggesting that a reverse gives you probably a better result as compared to internal fixation. I think that's probably the way to go forward if you have the skills to do a primary or a primary reverse. So if you look at this, this is quite interesting that in this particular group, there are various papers which suggest that in the elderly, even the complications of internal fixation are more than non-operative management. Okay, so that's just something to think about. That if you don't have a dislocated head, as Prathap said, if you can't get a good fixation, or if an arthroplasty is not an option, not operating would probably reduce your rate of complication as well. So that's something to think about in these cases. So I think the key to success is restoring the anatomy and getting a biomechanically advantageous situation. Getting the tuberosity union, especially the greater tuberosity, gives lesser complications and better range of motion in a reverse as well. And I think to conclude, it is a very attractive option for complex fractures in the elderly with more predictable results than ORIF or Hemi. But there was an interesting paper which suggested that there's a learning curve, which probably is about 20 cases. So I think it's best to start off, with someone who has significant experience in doing reverse shoulders. And in spite of whatever, there is a complication rate for a reverse as well, with instability and infection remaining the main concerns when we are doing a reverse shoulder arthroplasty. So thank you very much. That was my take on reverse shoulders for acute fractures and sequelae of fractures as well. Thank you.
Thank you, Dr. Parag. And I mean, you can leave your conclusion slide, because this more or less sums up the constant debate that I have in my mind, and as a general trauma surgeon would have. We can't keep on debating with Dipit. So coming back to this slide, so you said that there is a learning curve of 20 cases. Now, what I wanted to ask, put another spin to it. Would you, as a general orthopedic surgeon, be more comfortable operating on reverse shoulders in elective cases and then moving on to trauma? Or trauma is a much easier if you had to choose an ideal patient to start doing your reverses, would a trauma be a good one to start, or would you go for a cuff?
So I think, again, we are going to delve into the realm of more core shoulder surgeries. But I think in my experience, the better cases are actually the ones, the elderlies with osteoarthritis. So I think, those are the ones where you can start doing, then get on to cuff arthropathies, and then get on to acute trauma.
Right.
Because, the instability part is something that is something that concerns me, especially if you are a beginner, and this is a very complex system. And sometimes the results are also dependent on what kind of system you use, your familiarity with that particular system, and how do you intraoperatively treat situations, which might go a little bit out of hand. So I think it's not a very simple surgery to begin with. So I think I would probably start off with non-trauma cases, and then get on to ask someone, to get on to a trauma situation like this.
Right. The other thing was, the position and execution of the surgery. Would your approach and position be the same if you are planning for a fixation or a replacement? And would you have made up your mind before you start the surgery about what you are going to do?
See, most of the times, yes, because, unlike a lot of these Western countries where they have things on the shelf, we don't have things on the shelf. So I can go from a hemi to a reverse or vice versa. But most of the times when I'm going to start, I think it's a pretty clear decision preoperatively that it's definitely not going to be an internal fixation.
Right.
Because you can't really think of, okay, I'm going to do an internal fixation, plus or minus a hemi or with or a reverse. So I think in our setup, most of the times the decision of an arthroplasty is already made. There have been few situations where I've gone in, and I have gone in with the thought of a reverse, but I've got very good tuberosities. The cuff is excellent, and you believe that you can get away with the Hemi Arthroplasty as well, and I've done that.
Right.
And in few occasions, I've had to shift from a Hemi to a reverse again because of unfavorable condition of the rotator cuff. So I think that the first lady that I started out with, you could consider or argue to do a Hemi, but then intraoperatively you could see, as I showed in the slides, that she had no supraspinatus. Even the infraspinatus was pretty, degenerative. So I think that would be the case where even if I had thought about doing a Hemi, finances permitting, I would obviously shift to a reverse.
Right. So, Dr. Prathap Kumar, I mean, as a president of the Shoulder Elbow Society, again, I would like to ask you, if you look at it philosophically, I mean, there is an evolution in the understanding of fixation of the fractures. There is evolution in the understanding of the way we are doing reverse shoulder replacements. So what was told to us that, reverse shoulder carry a 30% risk of, complications or problems, especially in the lesser experience. Similarly was a trauma. So where do you see this evolution heading? I mean, the trauma results are also not getting worse, isn't it? They are also getting better. The reverse shoulder results are also getting better.
Exactly. So as Parag said correctly, there's a learning curve, and as more and more surgeons are into it, and they are more and more surgeons are experiencing with the reverse shoulder, then probably if you judiciously use that procedure, it's going to be better. Again, as Parag said, 70s, I don't want to do anything below the age of 70 years. I don't want to get into a reverse shoulder. That is my cutoff. I have seen people, say, when I was in Sweden, I have seen people doing it for 50 years. And he was the designer for the DP1. And in his hand, the result is very high. But I don't think that can be. So look at the literature. These are in the literature, and you cannot reproduce that thing with you. They are doing only that. Only that. Okay, he is doing only reverse shoulders. Right. Whatever condition comes in, so that cannot be duplicated in our daily practice. So my cutoff is 70 years, and if even with the 70 years, if you got a very good cuff, my personal choice is osteosynthesis.
Right. So contrary to what the literature shows, or let's say the Western literature shows something, do the Indian shoulder surgeons or the Indian surgeons who are doing reverse for trauma or fixation for trauma, do they have a different outcome? Do they have a better outcome? Because we never hear them saying that, they don't have as many complications as the Western literature are showing.
No, if you look at the reverse shoulder, if you look at the literature, it's as high as 37-38% reverse shoulder. The varying degrees of complication, but there is something like 37% of complications, maybe minor complications, everything included. So it's not, this is a major surgery, and you don't have a fallback phenomenon here. The next fallback is probably you may be able to do some sort of revision with the bone exchange and the bone adding procedure. And if that fails, then it's going to be arthrodesis.
Right.
Yeah, so you need to be very judicious. We don't want to give a
wrong message.
Yeah, loose comment here. And it's a very judicious, and if possible, that is my take.
Excellent. Excellent. Dr. Dipit, any questions from your side? Or any
no, I would like to ask something. It was a good presentation. Parag, very good results, and I think I agree with most of what is said. I think the results are very predictable as compared to internal fixation, because internal fixation is, of course, sometimes very, very dicey. I just needed to ask this now. When you're doing your reverse, and I do a prosthesis which has an angle of 147. And I think your prosthesis, whichever, I think you're using the Evolute is the one that you showed, probably has the same amount of angle of the neck.
Yeah, it's the same. I think it's the cut is about 135, and with the metaphyseal component, it comes to 142.5 degrees. So that's the Evolute one. Yeah.
So in
So,
145 degrees, when you are, repairing the GT, it is more distalized. So the mechanism has changed and it is more under stress. So does it heal? Means have you seen after 1 or 2 years, how is the GT? Has it healed up? And then again, in the non-union case versus the fresh cases, it would be a little different. The cases showing healing. And I think it may make a difference in the results overall. But does it really heal the, in fresh cases versus the non-union cases?
yeah, so again, obviously the fresh cases are better in terms of getting the tuberosity. So I mean, I've also been in the recent past primarily using the Zimmer prosthesis as well. But I think irrespective of what you use, the lesser tuberosity, I find it more difficult to bring it back rather than the greater tuberosity actually, because the amount of lateralization that you have with any play system makes it quite difficult for the lesser tuberosity to come back to its original position. GT, I've not found it to be that difficult. Again, as if you look at the literature and various presentations by Pascal Boileau, and they say that you want the GT lateral, you don't want it posterior. So I think that's the thing where you might have to struggle a little bit. In fact, over years, I've now gone on to a situation where I would probably put a smaller sphere to not lateralize and distalize so much to an extent so that I can get my GT in the best possible position. So I think that's the change that we've done. And I think that's where what I meant with familiarity with any system that you're using, that that.
I agree with you. I agree with you, whatever you've said. And the LT is definitely very difficult to get it back. But my question is, does it heal? Have you seen it healing after
Yes,
1 or 2 years?
yes. We have seen it in a number of our cases. I think majority of our cases where the GT has healed. I mean, and what I'm saying is it's not anatomically healed, meaning, it's not where it was before surgery, but it is healed on to the shaft or to the prosthesis to an extent that you can have sort of the ER2 as well as your ER1 sufficiently.
Okay. And there's no way to evaluate the LT if, I don't think I've been able to get the LT back to the same place. In fact, in some of them, I've just removed the LT and repaired the subscap by dissecting the capsule and that sort of thing. But LT, I'm not able to get back to its position.
I think in 50% of our cases, in acute cases, and nearly 100% of sequelae, we have excised the lesser tuberosity.
Yeah.
And especially in sequelae, it's just so scarred that no matter what you do, the subscap is not coming back.
Right.
And then we've left it at that.
Yeah. Right.
So we are also evaluating our first 50 odd cases that we've done from sort of 2011 to about 2016-ish, and seeing how they're doing, basically.
Right.
Excellent. Sir, any questions from your side? Dr. Shinde, sir?
No.
Okay, sir. Right. Thank you, Dr. Parag. Thank you very much. And excellent presentation and a very good conclusion with a sort of it drives home the message. Thank you very much.
Thank you.
I would welcome Dr. Vikas Agashe, sir. He is our senior colleague, a very dear mentor to almost all of us around here. And sir is going to take us through an interesting case that they have managed. And over to you, sir, so you can start sharing the screen, sir.
Thank you very much. I am honored to be amongst the shoulder surgeons.
Yes, sir.
Though I am not a shoulder surgeon. So this is a case before possibly this shoulder surgery evolved. And this was done in 2007, actually. So almost 15 years ago. So this was managed by me and my colleague, Dr. Vivek Shetty. And this is the X-ray. 63-year-old man presented 4 days after a vehicular accident with a wound like this. He was otherwise non-diabetic, non-hyper, right-sided dominance. History of multiple glass pieces taken out on the day of accident. There was already seropurulent discharge. The previous institution had taken a culture 1 day prior, which we got the next day, which was Pseudomonas. Finger and hand movements and sensations were normal. We could not judge his elbow and shoulder movements, obviously. Distal pulsations were good. He had multiple fracture ribs with minimal hemothorax. You can see that these are multiple fracture ribs. So I'll take you through the CT scan and then we will discuss. So that's the CT.
Oh.
So my first reaction was, of course, hum nahi karega. But unfortunately, the patient decided to continue with us. And now what should we do? I share the CT again. So he has markedly displaced comminuted upper end humerus. He has displaced scapula. He has shattered glenoid. He has spine of scapula. And he has a bad wound. That's the wound. And he has multiple fracture ribs, and that's the wound. So I think case is open for discussion. What should we do? Should we debride? Obviously, we should debride. But should we fix these fractures?
I think, can I speak?
Yeah,
Yes.
please.
Yes, sir.
Prathap. I think this we come across these scapular fractures and floating shoulders, and obviously the main problem there is soft tissue injuries and the chest injuries. So here with multiple rib fractures, a patient is conscious, isn't he?
Yes, conscious.
Okay. Yeah. Here we won't be able to go ahead immediately because of the chest injuries, or if you want to go ahead immediately, you'll have to put the chest drain. Otherwise, with the positive pressure ventilation, the pneumothorax is going to get worse. So either we can wait. Here already the patient has got infection, so we need to clear all these soft tissue infections by whichever means, by debriding and then IV antibiotics. So we got a window period, and once the 2 or 3 weeks is down the line, 2 weeks down the line, then we are okay, probably okay with the chest, provided we monitor the chest conditions, and probably will be able to do without the intubation, without the the chest drain. If not, then we'll have to put the chest drain, and then go ahead with the surgical plan. Well, it's going to be very difficult. Whichever way we go, is not only here the soft tissue the problem, and the bone is completely shattered. So we need to stabilize somehow. The clavicle is gone. That we can fix the clavicle once. We are talking about once the soft tissue is settled. Clavicle is reduced and fixed, and then the scapula is fixed. Now the question is debatable with what we need to go ahead with the glenoid and your humeral head. I don't know how much a humeral head is there. We don't know whether we got a CT there or not. The CT may be able to give you some idea about some idea about we got some sort of head there. So how old was this patient again?
About 60-ish.
60.
About 60-ish.
60. Okay. We will see whether
active man. Sorry, very active man. Very active.
So my preferred technique is some sort of a reconstruction using a graft, corticocancellous graft, and getting some sort of soft tissue back onto the position. And he may need a further surgery, depending on maybe may go into AVN. Then at least if we have got a greater tuberosity and lesser tuberosity back to some sort of position, then we can do
Suddenly we lost the voice.
Yeah.
Now we can hear you, but we missed the last part, sir.
Okay. My preferred technique is to get the soft tissue back onto. That is the most important soft tissue here is your cuff back to is a footprint, and reconstruct the footprint to some certain extent, so that even if we need to have a second surgery later for either reconstruction or a replacement, we can utilize.
Just to give one input, he did not have pneumothorax. He had minimal hemothorax. He had multiple ribs, but he did not have pneumothorax.
Very
minimal hemothorax.
Yeah, even with that, if you are going in first 2 weeks, then we will put the chest tube.
Okay.
I think that is the safest thing. Yeah.
Yeah. Dr. Parag?
Yes, I mean, it is, whether it's 2007 or 2022, I think these remain the really complex fractures to treat. Now, we've had some, experience of doing such bad looking, really, really terrible fractures. And so I think on day 4, if the cultures are showing Pseudomonas, and I'm not unduly worried about it. Obviously, he's going to go on specific antibiotics for the same. But I think I would do a minimal debridement to just clean up the local area, rather than doing an extensive open debridement, which would probably leave me with various bone fragments taken out and then making it very difficult for secondary reconstruction. So I think coming back to, if we were to do this right now, I think some of our hardcore trauma surgeons are now starting to fix ribs as well, to get these patients up and about and moving better and breathing better. So I think whether you do that or not is a secondary thing. But I think my take would be to, once he's hemodynamically stable, I would not rush in for his proximal humeral fixation. But I think I would do a staged approach and wait for about 7 days, looking at the skin condition and his overall status. I think the first thing I would probably do is fix his clavicle and fix his scapula. And I think by that time, the wounds on the arms would slightly start healing. And with continued intravenous antibiotics, I think I would do a delayed fixation of his humerus. Now, again, the CT suggests that I think there is still at least half of his head, along with, so that's his bicipital groove here. And that's his bicipital groove. That's his lesser tuberosity. That's probably a part of the head, which is going to come from the posterior aspect. So I think at a delayed stage, I would try to reconstruct this as best as I can. The good part is that most of the articular surface of the face of the glenoid seems to be good. So I think my approach would be to tackle this area initially. So the spine of the scapula, the acromion, and the clavicle. Hopefully, if I can do a nail of the clavicle, that would be even better, because that would prevent extensive open dissection. So I think first stage hemodynamic stability, IV antibiotics, early fixation of the clavicle and the spine of the scapula in first stage, and by about 4 weeks, fixation of his humerus.
Ashish?
Yes, I think this the exploration of the wound may throw. I mean, they have removed all the glass pieces. My concern is basically sanitizing.
Here were some pieces possible.
Yeah. So my priority will be sort of, to get a reasonable, pieces back into position in whatever primary alignment I can, and hold it maybe with wires or so. But exploration of the wound, getting rid of the contamination, trying to get control over the Pseudomonas. If actually it has penetrated deep inside. Only after exploration will we come to the status of the wound and maybe reclassify this open injury, whether I can expect a big moral level lesion also, so it is possible that the skin cover also may give me some problems in the future.
Dipit, would you like to add?
Parag is here actually. Parag has not seen the history, but Parag.
I think I'll just.
I've seen the history and I've seen everything.
No, not Parag Shah, Parag Lad.
Oh, yeah, Parag Lad is also there.
Yeah, no, I think I would just debride it initially and not fix anything in the first stage. And then wait for everything to settle down. And probably only fix, if I can, in the proximal humerus only. Scapula, I'll just possibly just conserve.
Okay.
No, I think, my gut feeling, I don't know what happens next, but my gut feeling is that it could be very boggy and there could be a big moral level lesion. So as I even start to debride it, my hand and everything might just, so I will be able to explore all the planes basically. So fixing it with something would make some sense to get on top of the situation.
Yeah, I mean, this was obviously, especially in 2007 when we did not have shoulder surgeons. Otherwise, I would have transferred the case to you people. Yes, we need to debride. There is no doubt about that. So this thing was, yes, we need to aggressively debride. There cannot be any doubt about it because there were glass pieces which were deep inside. So we had to take out that skin and soft tissue, etc. Question is, when do you fix? So we thought some stability has to be there. I mean, with this shoulder lesion, the clavicle, scapula, and humerus gone. That means the brachial plexus also is likely to be significantly pulled. So we thought we should fix it as early as possible. We thought clavicle we should fix first to avoid iatrogenic injury to the plexus. That was the idea. And then realistic expectations. I mean, obviously, we told the patient that we really don't know what is going to happen and we will try our level best. Even if you have a decent elbow and finger movements and some shoulder movement, I think you should be reasonably happy. So yes, he was told somewhere else that he is very likely to need an amputation. So this was okay. We also felt that the brachial plexus is likely to be injured. So we decided to fix the clavicle and humerus in one go. We excised this skin and went in because the skin was certainly necrotic. So we just excised it. The deltoid also appeared to be necrotic. We just excised that skin and deltoid and went in. We kept the anterior deltoid intact. That was fortunately reasonably all right. So first fix the clavicle with 2 interfrac screws and a plate. And then the humerus fortunately had decent soft tissue attachment. Here you can see part of the lesser tuberosity, as Parag had said. The part of the head was turned upside down. And that's... Now, after we did all this, we were wondering how come we have such a fantastic exposure. That was the time when we realized that we have a acromioclavicular dislocation. And that is why we had a fantastic exposure. We had till then not realized that. And so here you can see fixation of the acromioclavicular. The glenoid is absolutely shattered. We didn't think of scapula at this stage. We thought we'll repeat his CT. And our most important thing was the wound. After doing all this, if the wound is not very good, then we would be in trouble. So that's the CT. Shows the head humerus reconstructed quite well. Then we kept on debriding and we debrided twice before we put a split thickness graft. We got a decent coverage for our implants. And here you can see the, this is him. We got an EMG which shows C5 root avulsion. So as it is, the deltoid function could have been in trouble. This is him at 3 months. The shoulder is subluxated. But with all this, we thought fixing the glenoid would not be worth it. So this is at 3 months. He has no active abduction, but all other movements are quite all right. He is able to do most of his activities. And this is him at 11 months. That time he used to travel independently. He says, the only thing I can do is I can put my luggage on the overhead compartment. But otherwise, he is doing everything. So this is where, as I said, unfortunately, we didn't have shoulder surgeons then. Otherwise, I would have just transferred to you. Yeah.
I take that comment, but shoulder surgery is not the panacea for everything, unfortunately.
Right. Sir, I wanted to ask about the so one concern at every stage would have been debridement and implant retention, whether the pseudomonas is coming back or no. So at any stage was a thought given to local antibiotic delivery along with the systematic antibiotics? Was it required, not required? And
we just kept everything that was bleeding inside.
Right.
Not a gram of necrotic tissue. We confirmed twice, and then we put a split thickness graft.
Right.
By fortunately, we never thought that he is going other way. Today, maybe I would have put in. Today, since bioabsorbable stimulant is available, I would have put in today. But those days it wasn't available. Right. And we were not keen on putting the PAMA, antibiotic PAMA.
Right.
Excellent.
Okay.
Very good, very good result considering the C5 root avulsion.
Yeah. Thank you. Thank you.
Thank you very much, sir.
Thank you.
Sir.
Thank you. We have Dr. Neeraj Kasat here, who is a colleague from Bombay. And Neeraj, are you there? Dr. Neeraj has got a very interesting shoulder fracture and shoulder trauma to present.
Good evening, everyone. Am I audible?
You're audible, yeah. Neeraj. You can start sharing the screen.
Yeah. Okay. So good evening, everyone. After looking at all the cases, I realized that my case is a very basic one. So let me introduce myself. I'm Dr. Neeraj. I'm actually a joint replacement and spine surgeon, but I do a lot of trauma as well. After looking at Dr. Parag Shah's case and Dr. Vikas Agashe's case, I think my case is quite straightforward for all you guys. But for trauma surgeons, I think these cases comes once in a while, and managing these cases are very difficult. So I had a 55-year-old lady who sustained a railway accident.
Neeraj, have you started the presentation? Because we cannot see the PowerPoint. We can see your desktop.
Oh yeah, I started a presentation already.
No, then I think that screen is not being shared. What we can see a list of folders.
Okay. Okay.
In fact, we saw your account statement.
Now can you see?
Yes, it's much better.
Yeah. So now she is a 55-year-old lady. She sustained railway accident. I did this case in 2017, I guess.
Yeah. Can you go to the full screen view?
Yeah.
It's on the bottom right.
Yeah.
No, the button next to that, next to the minimize the button. Yeah. Yeah.
Okay. So she was a 55-year-old lady. She sustained a railway accident. She was chemistry teacher by profession. She was a diabetic, and she presented with she had a fall from a railway and she sustained right shoulder injury. When she came in the emergency, the X-rays were like this. She was in a lot of pain. So from the X-ray, I guess she had a comminuted proximal humerus fracture. Probably the head is split and probably dislocated posteriorly. So obviously I got CT images. These were the CT images. So Dr. Prathap, Dipit and Dr. Parag, will you please comment that 55-year-old fairly healthy lady, obese, chemistry teacher with this the fracture dislocation of the shoulder? Means how we should plan and go ahead.
Can I?
Yes,
Yes,
yes.
sir.
Okay. I feel that is it an isolated injury?
It is an isolated injury.
Okay, there is no other nerve injury. 50 at this age, whatever happens, I'm predetermined that I will reconstruct it. That is my that is how I go for this one. I use a corticocancellous graft and reconstruct it, and I can see that there's a decent head. Of course, it's dislocated and probably completely displaced. There's a high chance of AVN that I will discuss with the patient beforehand, need further surgery, but my idea is to reconstruct the soft tissues back to its position and to keep that varus angle, keep the medial side intact. So for that, I will use a graft, corticocancellous graft. So I will reconstruct and I will get a decent soft tissue attachment to it. And then during follow-up, if I get into AVN or any other problem, then I have a choice of going ahead with the replacement on a later date.
Dr. Parag, what are your thoughts?
I think similar to what Prathap said, I'm just considering the fact that she's neurologically intact and, hemodynamically stable and etc. So I think these are slightly what I would call a sort of a nutcracker fracture, because you have a head which is split in two pieces, and I think from what I see, I think these are very small images, but I think you have the lesser tuberosity along with this part of the head, and I'm presuming that at least a part of the GT. Now this is the LT here, probably a part of the GT and the bicipital groove intervening in this anterior fragment. And the posterior fragment would probably, the posterior part of the head would still have some part of the GT remaining, or so is my hope. So I think I would agree with the fact that I would fix this fracture, I think, in a 55-year-old individual. And again, there may be some merit, as during my talk, Ashish and we just discussed that you have to get some things on the shelf. A Hemi might be my fallback in a situation like this, but so my first preference would still be fixation.
Yeah, so I also thought of the same thing actually. Looking at the CT, the head size looks decent, and if you have some capsular attachment, we get back everything in place, then probably osteosynthesis should be the first option. But when we dissect, when we go ahead with the deltopectoral approach,
can I ask a question? Can I ask a question to surgeons? How would you address the markedly displaced head posteriorly?
Yes.
Any tips and tricks about that? Because this seems to be.
Can I speak on this?
Yeah.
Sir.
Yeah.
So now how to approach the head and reduce it is the punchline in all this. You can reconstruct it.
Yeah.
You can get a good anatomically looking X-ray and everything. But the way you've reduced the head, there lies the secret.
Correct.
Now if the LT, LT has, I cannot see if the LT has a part of the head attached or not. There may be a little bit, but most of the head is one piece. Now, I used to go between the rotator interval. Now, because you already have a LT, which is completely separate. Now, if you have a complete LT separate, so you already have a window through which you can go because the GT is away and the LT is away. Now, off late, just to preserve the envelope, I go in the rotator interval, which is above the LT. you have to remove a bit of the CA ligament, and we do an indirect reduction, maintaining the envelope. That is more difficult, but that is, that maintains the vascularity. But the way you means if you remove the subscap from LT, then the story is over. It will never recover. Now, if you can reflect the LT with subscap and find a window, and it's a young guy, I think still he has a good chance. I don't have an experience in old people, how they perform, but that is one of the options how you can reduce the head.
I think if I may also add to this, again, there is no doubt that the LT subscap, the attachment with the head, everything needs to be preserved. One thing which I've found quite useful is to go extensive on the medial side of the shaft, which means that I first of all do a tenotomy of the biceps and get it out of the way to go through the interval. But I think a lot of times, if you can move the shaft around a little bit, it always helps. Now, for me, that means that I take down most part of the pec major, including and the latissimus dorsi and the teres major of the medial side. I reattach them at the end of the surgery, especially in a younger individual. But taking this off along with the periosteal thing on the medial side can get you the entire shaft significantly more mobile. This it sort of forms an invisible wall on the medial side, which prevents your translation of the head, of the shaft, I mean. Removing these structures of the shaft does not contribute anything to the vascularity of the head, because the vascularity of the head is solely dependent on the capsular attachments and perhaps to the tuberosities in some way. So I think this is one approach that helps me in a lot of complex proximal fracture dislocations, is to take down your pec, the latissimus, and the teres major of the humerus. It also helps in reducing your traction on the radial nerve. One must understand that the radial nerve passes very close, and there are significant number of proximal humeral fractures where you have an injury there because iatrogenic, because you're too close to the radial nerve and you're manipulating the shaft quite a bit. So for me, removing these structures of the medial side of the shaft helps in exposure significantly.
Parag, can I? Yeah, I absolutely agree with you. So long as the pec major is intact, you will be struggling till after an hour you will start releasing it. So go early and release it. Subperiosteally release it, and probably the deltoid tuberosity as well. Release it. So that we don't have to struggle. And as you said, it's nothing to do with the vascularity.
So I just want to ask each one of you that when we are dissecting it, though the head size looks quite good on the CT scan, but when I dissected and retrieved the head back, the size was not even the 50% of the humeral head. I'll just show you the picture. It was like this. So it was all shell inside and it was just outside. Now, how to fix this small fragment back? There are 100% chances of even with this small size of the humeral head. So now after looking at this, you will still go ahead with osteosynthesis, Dr. Prathap?
Yes. I don't mind having AVN. I don't mind having AVN. What I'm worried about is the soft tissue covering there. See, shoulder is all about soft tissue coverage and biomechanics of biomechanics is exclusively controlled by the soft tissues there, your cuff. So long as you can get the footprint back to where it should be, almost to at least a 90% correct to, or at least 80% correct to where it should be, you got a choice of doing something later, okay, rather than you give up and then getting the wrong side of the biomechanics. So I will definitely fix it with whatever available bone, and I don't usually I don't put any free screws, but here I won't mind using a headless screw.
Okay. Anyway, I went ahead with when I didn't do osteosynthesis for this patient. I did Hemi Arthroplasty for her. I used the bone graft to fill in the gap. I sutured back the greater tuberosity back to its place, though I couldn't get it back completely down. And she was a chemistry teacher. She has to write on the blackboard I told her that she may not get a decent range of motion after surgery, but she was so dedicated in physiotherapy that at 4 months she was like this. And when I saw her after 2 years, the range of motion was full. My only worry is now the greater tuberosity is there. There is a non-union at that site, which is asymptomatic, no problem. Is there a worry if the greater tuberosity doesn't hit back to the bone?
It's a fibrous union, isn't it?
Yeah, so
Yeah, it's a fibrous union.
This is a little, I cannot understand. So if the GT is not united, but you still have good movement, it's a little perplexing. Because
so it's asymptomatic, patient has full range of motion, and the X-rays are like this.
Yeah, no, of course, if you see the X-ray, then you don't think that she'll have good result, but then she has good results. So I think it's good. If the end result is good, then that's all that matters. But the GT is a concern. Definitely, this GT is gonna get reabsorbed because it is not uniting.
Again, Dipit, if at 2 years, if the GT is still there, I think that means that it is vascular. And at this stage, I have not seen delayed resorption of the GT at 5 years. I think if it's going to resorb, it's going to resorb in the first, 6 to 12.
But how is it not united and still she has?
No, so I think here it is this one view which is perplexing a little bit. I think there is probably fibrous union there, and probably it is united probably at the back or maybe even to the implant. I think that's and its relation to the head is reasonable. I think I'm not sure. Even the LT may not have completely united here, but I think nothing succeeds like success.
Yeah, that's what I said. So you cannot explain on the basis of the X-ray. It just doesn't match up. But then if the results are good, then that's all that matters.
Okay.
Very good.
This was my case. Thank you. Thank you.
Good. Right. Thank you very much, Dr. Neeraj. And before we proceed, I think we are coming close to 7:30. There are a few questions that have come in for all the three lecturers and speakers. So I'll start with the first one. Dr. Prathap, I think this is a question for you from Mozimul Siddiqui. And he says, can you guide us how to choose between a cancellous graft and a cortical graft for proximal humeral fractures?
Okay.
And
fine.
There is another question that sort of can go with it, is by Dr. Nitin Patil, and he says, what is your experience about using an allograft?
Okay, I always use an autograft, and always use the corticocancellous graft. What we need is a minimum of 5 centimeter of a corticocancellous graft, which is always easy. The only thing is that it's not straight; it is bent, but we can utilize it as I was placing it with the convexity medially. So it will perfectly sit in there. Okay, and it is going to be stable even without any screws. And you can use the screws, the proximal most shaft screw will go through that. And your run home screws, the Calcat screws, that will also definitely go through that. So it's going to be 100% stable. So that is the one which is going to tackle your virus stability, valgus virus stability. It's not going into virus anymore. Plus, you are going to neutralize your cuff, your supraspinatus, by using number 5 ethibond. So this combination is a very good combination. And when you take a corticocancellous graft, you will always take your some more cancellous graft as well. So that, because there will be, after debridement in non-union, there will be a lot of free spaces. So you can fill it with that. And I will never use any allograft. No. And my preferred technique is from the ilia crust. I never used it from the fibula.
Okay. Excellent. You mentioned not using the fibula for these earlier on. Yeah, so
I don't fancy, because I think the other one will heal very nicely without any trouble. Yeah.
Excellent. Dr. Dipit, you must have read in the chat box. The next question is for you. Dr. Nitin Patil asked, how many times have you needed to do a bicipital tenotomy in anterior dislocation? There are a couple of more questions regarding your talk. The second question is how to avoid an adherent humeral head injury with the osteotomy. And is an open reduction better for anterior neglected dislocation without a cuff tear at 3 weeks, or can arthroscopy be tried? The questions are there in our chat box.
In our chat box?
In our chat box, yeah. I've copied pasted them there.
Yeah, so which one is it?
The first one starts from the lesser tuberosity osteotomy for McLaughlin procedure, deep or superficial?
Deep or superficial?
Can you describe?
I think I do the complete lesser tuberosity osteotomy, not deep, not superficial. I take the entire chunk of the bone off not with an osteotome. I use a saw and I remove the entire LT with the subscapularis. So and the second question is
by Dr. Nitin Patil. How many times?
Second question is how many do you need to do bicipital every time? Biceps is hated. How many times you need to do bicipital tenotomy and anterior dislocation? You need to understand when you're talking to a shoulder surgeon, they hate the long head of biceps. I have not kept the bicep intact ever in my life in these cases. No, I mean in these cases. In fact, also in rotator cuff tears, and especially in these cases, each time you have to cut it. I mean, that is a step which is considered in my hand as an exposure step, not as something which I specially take care to do. I cut it each and every time there is a dislocation. How to avoid humeral head injury with the osteotomy? So,
Dipit, can I ask you something about this bicep?
So the level playing of osteotomy, you have to decide after seeing the CT scan in mind. So what yes, sir.
No, just a question related to that. Do you mean to say that biceps long head is a vestigial organ now?
Exactly, sir. It's an appendix. It's the appendix of the shoulder.
Okay.
So any danger that you consider that this will happen, that will happen. There have been more than 10,000 shoulder surgeries happened every time they cut off the long head of bicep. They of course stenodeset it with the pec major tendon, but in rotator cuff tears, we just cut it and leave it in old people. Nothing happens. It's pretty safe. In fact, you should never think twice. Biceps tendon has to go. I mean,
hey, once you call biceps tendon as a lighthouse of the shoulder, in the next moment you are.
It's not agreeable. Whatever Dipit said.
Yeah.
I actually, it's like the praying mantis maneuver.
Yeah.
That once you use it as a lighthouse, then you chop it off. As the mantis, after the meeting, the female just bites off the male's head.
Exactly.
Okay. Once you know the lighthouse, then you kill it.
Yeah. First it is our savior, then we destroy it.
Okay.
So yes.
Sir, you said you're not agreeing with this comment, Dr. Prathap, sir.
Yeah. No, I don't agree with that. As far as if you look at the biomechanically, this is the long head of biceps. I am talking about youngsters, okay, not the old age people. Old age people, we always use it for reconstruction with the anterior part of the supraspinatus. So we need that for, you don't want to, lose it. So in youngsters especially, if you look at biomechanically, the anterior cuff and posterior cuff. Anterior cuff is your subscapularis plus long head of biceps plus the anterior leading edge of supraspinatus. So it's an important part of it's a part of your cuff. How important? We are not agreeable still now. So I don't want to just go and chop it off. Parag.
Yes.
What is your opinion, please?
I think even in young patients, when I'm dealing with complex trauma, I always take it out and I always tenodese it, and I've never had any regrets in that. Now, I mean, we are talking only of currently trauma situations, so it's a different matter when we're talking about hardcore shoulder surgeries and the biceps being used for as an biceps SCR or a biceps DAS. So that's a different matter altogether. But when you're talking about trauma, when you're talking about dislocations, when you're talking about neglected situations, I agree with Dipit that it's a part of the exposure, because you take it out, that literally opens up your interval and lets you do a lot of intra-articular maneuvers as well to reduce dislocations, head split fractures, fragments, etc.
Just to put things in perspective, I'll just give you, sir, Agashe sir, I'll just give you an example. So there is a band of shoulder surgeons in Europe, even in America now, many of them, they consider long head of biceps to be so vestigial and useless organ in young people, even in sports, that they cut it off in young adults who have recurrent dislocation and transfer it to the glenoid.
Yeah.
They are cutting it off from the supraglenoid tubercle, and they are rerouting it to be used as an anterior restraint and fixing it to the anterior glenoid. They consider it completely vestigial in young sports person and 20-ish people. And there are too many publications now coming out, which will be a feature in our next newsletter of SESI. So that is also happening at some part of the world. We are not doing it, but that is happening. I'm telling you, that is happening at some part of the world, and many people are doing it now.
So we'll wait and see. I mean, because a lot of things have gone on with the longer the bicep. Sir, you're saying something and we can't hear you, Dr. Agashe.
No, I said thank you. Sorry for starting a controversy.
No, it's not. So next question is how to avoid inadvertent humeral head injury with the osteotomy. So the osteotomy plane has to be decided looking at your CT scan. So it is actually going from the front, which is you've exposed the bicipital groove. So you know the LT is just next to the groove. So you start your osteotomy from there and you go towards the posterior glenoid because that is where your LT ends. Basically, that is something which you learn with after a couple of procedures. But yeah, so it is a complete osteotomy and the plane has, I mean, you can decide the planes looking at the CT. Next question is open reduction better for anterior neglected dislocation without cuff tear at 3 weeks on an arthroscopy we tried. See, arthroscopy is what I've tried and it is still in development. I cannot tell you it will achieve each time. So if you have a anterior neglected dislocation without cuff tear at 3 weeks, you probably should do it open. I am trying arthroscopy. I'm just pushing the envelope each time. I cannot say that is the standard of care. You should do it open. And then the next question is how to improve stability in fracture with reabsorbed tuberosities while doing a RSA. That Parag will answer this.
Yeah.
You want me to take this now?
Yes.
Yeah. So, okay, always a problem, when you have resolved tuberosities, but then you have to improve the stability. There are, again, there are a few ways of doing that, but one of them is to increase the size of the glenosphere. So larger the diameter of the glenosphere, the more stable your reverse shoulder is going to be. There are some other ways that there have been people who have actually, even though the GT is not there, the cuff on it is not there, they've recreated the GT with cement, and what they claim is that it improves what is called the deltoid wrap. So the contour of the deltoid in the presence of a GT itself is supposed to improve the stability. So I think a few tips and tricks are to have a larger size of the glenoid, have more distalization and lateralization. Again, this is hardcore reverse work, whether you want to lateralize the glenoid or you want to lateralize the humerus and things like that. But in a nutshell, try to have the maximum diameter as possible when you do not have tuberosities. I think that's probably my most important tip.
Okay. And then there is another question from Mozimul Siddiqui. How do you make sure the entire head pieces are extracted in the head split variety?
I think by fluoroscopy.
Fluoroscopy. Okay.
And if I may just add, to the first question as to the Leicester tuberosity osteotomy for McLaughlin. So again, I have very extensive experience, a very large case series yet unpublished. But what I do is, again, going back to Agashe sir's question, and I tenotomize the biceps. And in fact, I start my osteotomy from the bicipital groove itself. Okay, that actually increases the size of the bone chunk that I'm going to get. And, especially in chronic cases where you have very large liver cell sacks, you want good real estate there. So I think I start my osteotomy from the bicipital groove itself. taking the entire or as much chunk of the lesser tuberosity as possible, so that I can get the maximum best fit once I reduce the head which has been dislocated posteriorly. I think the problem happens is that when you have, it's a very common fracture pattern to have a posterior fracture dislocation or a posterior dislocation with an LT fracture. So when you have an LT fracture associated with that, then you are a little bit handicapped by the amount of bone you can take, because the LT is already fractured. So I think that is a little bit of a problem when you already have, let's say, a very small piece of LT, and then you just have to make do with it.
Excellent. I think we are quite over time anyways. Dr. Shinde, any comments you would like to make before I ask Dr. Anthony Joseph, who is the secretary of our guest state body, the Kerala State Orthopaedic Association? Dr. Anthony Joseph and Dr. Ajit Shinde, sir.
I think that now we should conclude the session. Enough discussion has occurred,
Yes.
and we heard a lot from the shoulder surgeons.
Thank you, sir.
New concept we heard.
Thank you, sir.
Thank you,
Dr. Anthony Joseph.
Thank you, Dr. Ashish. It was a really good learning experience. First of all, let me thank Dr. Atul Shrivastava, the President of the Indian Orthopaedic Association, for taking off his time to inaugurate this webinar. I thank Dr. Ajit Shinde, the President of the West Bengal Orthopaedic Association, and especially Dr. Ashish and Dr. Ajit for conducting this webinar beautifully. I thank Dr. Prathap sir, Dipit Sahu, Dr. Parag Shah, and Dr. Vikas Agashe for the nice presentations, and also Dr. Neeraj Kasat for the case presentation. Kerala Orthopaedic Association would love to continue doing webinars like this, and we hope we'll coordinate more in the future.
Thank you very much, sir. Thank you very much.
Thank you, everyone. Thank you very much.
Bye-bye. Bye. Bye.
Thank you. Thank you, sir.
तर कुठेकडे जायचं बंद करायचं का?
मीटिंग